Hello, everybody, and welcome back to the B School. Be better, be empowered. Today, I am Dr. Emery Pitcel.
And I'm Rebecca Hall.
I was gonna say I'm Dr. Emery Pitcel every day, so there you go. I'm joined by Rebecca Hall. She's one of the best massage therapists in town. To humble brag on her part here and everything. And we thought it would be valuable today. We are in June, so we know a lot more people are going to get active back on the bikes and get back into hikes and get on their runs and everything. And we thought it would be really valuable to kind of share some inside knowledge on the gluteus medius muscle, right?
Yeah, I'm really excited. This is one of my favorite muscles to talk about. I think it's super important and super undervalued. So really excited about today.
It is. And there isn't really a rehab. I don't think there's really a rehab provider, whether it's a chiropractor that does a good amount of physical rehab with patients or a physical therapist that doesn't at some point highlight the importance of glute med and try to bring that back up to speed. But we're getting a little bit ahead of ourselves. Let's start with how common are we running into problems with the glute med? Now, if you've joined us for some of the other episodes, we have actually kind of picked on more like muscles and tissues that tend to get like adaptively shortened and then therefore painful as a result of this. This one's going to be a little different. More often, we see that this is a muscle that is actually underutilized and insufficient in its strength and firing, which can still ironically lead to tightness. But like there's tight and weak versus contracted and weak. This usually is a little bit more of the tight and weak variety. And studies in the NIH show that we could be talking about like involvement with like hip pain, low back pain, and buttock pain in as much as 20% of people being insufficient at the gluteus medius.
Yeah, definitely.
So that's 1 in 5, right?
Yeah.
If you're telling me something is going to happen about 1 in 5 times, I think I'm going to pay attention because that's often enough that we're going to see it frequently enough, right?
Yeah, 100%. And you basically hit the nail on the head with what kind of causes that pain, right? A lot of times it's that insufficiency and not firing correctly, right? Because our glute medius is really supposed to help kind of like abduct and also like externally rotate that hip, right? So when we bring our knee kind of out to the side, that's the motion that we're kind of looking for that to assist with, right? But the problem is if that muscle gets over lengthened because of either kind of like rotation of the hips, maybe some other muscles firing the way they aren't need to. We'll kind of get into that a little bit more, I'm sure, as we go down the list. But as that rotation happens and that muscle kind of gets either lengthened or just like shortened but weakened or inhibited, right? If we're talking about neurologically standpoint, that can cause a lot of issues where it's not firing correctly, and then other muscles have to kind of pick up the slack, right? And that's where we're starting to get our joints aren't moving the way they need to. Our hip and our pelvis isn't moving the way it needs to. And then we're getting knee pain, we're getting glute pain, we're getting back pain, right? It can lead to a whole bunch of different issues because it's not stabilizing your hip the way it needs to.
Yeah, really, really well put. If I may just add a little bit more on the causes of pain, because I love how much you talked about, like, first of all, you talked about the function of glute med, which was great. It's an abductor and an external rotator. We'll add a little bit more later as to why that is very significant. But I think how do you get yourself in a position where you have that pelvis, like, tilted incorrectly, that hip, like, adaptively shortened where the hip flexor is taking off the load and a lot of the glutes are kind of shut down? We're doing it right now.
Yep.
You and I. As I was going to say, I don't like to oversimplify things, but sometimes simplification is the ultimate sophistication. If there was one thing that I said is the problem that's creating glute medius insufficiency, it is sitting too much and sitting with poor posture. Would you not agree with that?
I would 100% agree with that. We are not a good postural, stable society.
No.
So unfortunately, this position puts us at a greater risk to turn off that glute med because a lot of times we're inhibiting it just sitting here.
Yeah. And I know because you have athletic training background at Penn State, right? Let's not to call out like the student athletes out there, but like let's call it out.
I call them out all the time. Don't you worry.
But let's call it out for what it is, because like you go to practice, you work your tail off at practice and everything, and then what do you go? You probably have like 2 or 3 or 4 lectures, maybe a lab or whatever it is, or you go home and you study, and then you've done all that work. You've tried to do a great job doing your cool down and try to like bring everything down, but then you go for 3 to 4 hours,
Mm-hmm.
and you just basically take like all those strength gains that you had and you just neurologically re-shut off the glute medius again, right?
Absolutely. Well,
Yeah.
and especially you think about when you've warmed up the muscle, maybe you go to practice or lift before you go to class, right? You've warmed up that tissue, you've worked that tissue, it's tired, and
Hmm.
now you're going to shorten it or keep it in an inhibited position. It's going to lock down in that position. It's not going to want to stretch back out until you warm it up again, right? And even then, it's not going to want to fire the more that you do that pattern.
I agree with you. I agree with you. So I think now is a relevant time to move into where do we see pain then? So if we're going to have insufficiency at the glute medius and typically tightness there, what I actually find is the pain. This is one of those muscle areas where the pain doesn't necessarily show up exactly where you should expect it to. Yes, it's showing up in the glute and the buttock, but typically it's going to be, as you alluded to, other muscles that are picking up the slack for the insufficiency that's living at glute medius. So thinking like that rim of the buttock that's like almost right at the very bottom of the back, what we call the superior division of the gluteus maximus. A lot of times the piriformis will try to pick up that rotational behavior at the hip because the glute medius isn't working the way that it does.
Mm-hmm.
So yes, you'll get butt pain, but it's not really butt pain as a result of the gluteus medius. Sometimes as that's insufficient and you just kind of have this mismatched joint kinematics at the hip, you're going to then start to see that anterior front of the hip pain, like somebody almost saying like it's a tight hip flexor. And yeah, the hip flexor needs to be worked on, but the glute med needs to get brought back on board as well too. And anytime you're going to kind of get hip or low back involvement, the door is always open for the possibility to have radicular symptoms all the way down to the knee or even below. Usually, typically with this, fortunately, it's going to usually stay above the knee. But if that piriformis does clamp tight enough and grab the sciatic nerve, you could get stuff all the way down to the heel.
Mm-hmm.
So it could be very dispersed with where you get your symptoms at, is my point.
Yeah, definitely. And just to add and reiterate that,
Please
right?
add.
Like,
Yes.
I think one of the other things that it does is when you think about walking or running or anything like that, like it's one of our major hip stabilizers, right? It really
100%.
helps you keep your pelvis where it needs to be. So if you don't have a good glute need strength, right, then your hip can drop. And we use females, right? We have a larger Q angle is what we call it, which is basically if you put your hand on your hip there and then go to your inside of your knee, when you're standing up straight, that angle is called your Q angle, right? Females tend to have wider hips, right? And so the greater that angle is, the more that we're likely to have maybe anterior knee pain or medial knee pain. And if our glute med isn't working to stabilize and bring our leg back out where it needs to be straight, then it's going to drop and you're going to hit and get that medial valgus move. And
Mm-hmm.
then you can get that medial knee pain as well. So that can be another kind of big thing when we're talking about where we're finding pain. That's something that I see a lot in my practice, especially as an athletic trainer.
Well, I'm so glad that you brought it up because we said this. We did an anterior knee pain episode a month or two ago or something like
Yep.
that. And we used the exact phrase is that, yeah, you have pain at the knee and we need to work at the knee. But a lot of times we got to go either downstream and look at the ankle or we got to go upstream and look at the hip. That's where this conversation plugs directly into the one that we did a couple of months ago. I'm
Absolutely.
so glad that you highlighted that. It also felt like you were starting to tease some of the common complaints of like lost function or activities that get altered as a result of a glute medius insufficiency. So could you please take the ball and run with that?
Yeah, absolutely. Yeah, it's a perfect segue into that because, again, one of the things that I majorly see is that knee pain, right? And when I have any client or patient that comes into the clinic, the first thing I'm looking for, if they have knee pain, I'm going to look at the hip, right? I'm going to look at their ankle, I'm going to look at their hip because we always have to get the bigger picture, right?
Yes.
But a lot of times, if that glute med is insufficient, we're getting that knee pain, we might get hip pain, like you talked about, right? I see a lot of clients that come in and say, like, yeah, I just don't feel stable, right? Like
Mm-hmm.
maybe they started running again and did the kind of a couch to 5K, right? And they're like, yeah, my hip feels weird or it clicks or it doesn't feel stable when I'm landing on it or I get low back pain now or, things like that. So a lot of times when you have that overactivity, without sufficient stability in the muscle that's supposed to be working, right?
Yeah.
Everything else is working so much harder to get to that same point,
Yeah.
right? So that's one thing I see. But on the other side of things, I have people come in that say, it's just, like my hips kill me when I sit.
Yeah.
When I sit for too long and I stand up, it's like, ow, like it just feels tight. It feels crampy. It
Mm-hmm.
feels like it doesn't want to stretch. I don't know how to stretch it.
Yeah.
And a lot of times that that like you want to stretch this muscle is kind of a sign that, you know, yeah, maybe you need to stretch it, but a lot of times, like sometimes it's over lengthened and you need to actually just activate it, right?
Yeah.
Because that stretch sometimes is like our neurological way of trying to get the muscle to fire, but a lot of times that doesn't work.
Mm-hmm.
So
Yeah.
trying to get it to, you know, um, neurologically activate, if you will, is going to be the best way to kind of get that on, more than just like sitting there trying to stretch your hips.
Yeah. No, I love that. That was really good. So glad that you went into the discussion with seated, because I think you and I were very much on line with saying, you know, that when we think about these muscular type injuries, we're really good at thinking about like what are the overactives
Mm-hmm.
or like the active activities that got lost. So love that you hit running. That's amazing. Thinking about like the baseball player that can't sprint and then round the bases
Mm-hmm.
because they don't have like that pelvic stability, but even just like walkers and hikers are going to have
Yes.
complaints as well too. And then sitting, yep, definitely have problems with sitting. Maybe one other thing to possibly splash in there as well too is sometimes with the glute med being insufficient on one side, that's then when somebody's going to say like, I'm a side sleeper. I don't like being on that side, but I'm
Mm-hmm.
okay with the others. I think what I typically find is because it is, as you said, an abductor and an external rotator, it's actually going to be like sometimes ironically the side that's up that's going to hurt because then you're sleeping and then the hip falls down and in and it's like a little bit flexed in kind of that slightly fetal position, so it's already a muscle that's maybe already over lengthened and now you're just keeping it over lengthening and it's talking to you and telling you I don't like this. And then
100%.
sometimes when you actually then go to sleep on the side of the hip, it actually kind of adds that stability back to glute med and then you might actually ironically feel better because people are used to thinking like if more classically, I think you and I see, right,
Mm-hmm.
that if a hip hurts, that's usually going to be the side that people don't like to sleep on, and then
Correct.
the opposite one feels better.
Mm-hmm.
This one kind of flips the script a little bit, or that's at
Yes.
least what I've found. Sometimes when I hear that story of like it's actually, I feel better when I sleep with the well side down
Mm-hmm.
instead of, or, you know, I feel worse when I sleep with the well side down. That's what I meant to say.
Yeah.
Then that's sometimes maybe a cue that we might need to look at your glute med,
Right. Absolutely.
right? Anatomical
Your
connections,
favorite.
right? Yeah, yeah. Well, I like our cross syndromes. That's how my brain likes to think, and that's also how I am able to therefore justify that, hey, segments and regions above have influence on the area that we're talking about, right? So
Mm-hmm.
if we are talking here, and I already kind of like alluded to it on where is the pain, right? But if we have an insufficient glute medius, which again, about 20% of the populace that has pain does, then the muscles that are going to kind of take up the workload around that again are kind of like certain bands of your gluteus maximus, usually like the superior division. That piriformis is going to kind of take up work as well too. You could start to get even like the gemellus and the obturator internus and externus. Those are words I have not thrown out in a while, but those guys will come in as well too. And then you're kind of going that cross pattern across the hip. Usually we got this concept that's called reciprocal inhibition, where it basically means that you can't have two things pushing at the same time. It's kind of
Mm-hmm.
like a teeter totter. So if one is up, the other has to inherently be down. So if the glute medius is down, typically to kind of make up for that, what you're going to find is, like you said, that hip is tight. I'm stretching it. Why won't it get like, why does it keep getting tight at my hip flexor? Because you're doing a great job relaxing that hip flexor in the moment, but the underlying problem is really that glute medius needs to get stronger. And so that's that crisscross pattern across the hip where it's like weak there and maybe a little more overactive there. And so then we crisscross over and then we get like too tight and overactive at the hip flexor. And then usually the group that's going to go along with it, act surprised, is the abdominals are going to be weak along with it,
Mm-hmm.
especially like your obliques and your rectus abdominis. So that's kind of like the connection pattern that lives across the hip, and all of that can kind of just contribute to the pelvis and the hip position not being where it's at, or it could have been that the pelvis or the hip positions weren't good and then it caused all of that. So don't we love saying, was it the chicken or was it the egg? And
Always.
then the reality becomes it kind of doesn't matter which one came first. It all needs to be worked on. We'll
Mm-hmm.
all unspool it together over the course of a treatment plan, and as long as you get better and you get stronger and you're more stable, then that's what needs to happen.
100%. Yeah, absolutely. And I think the only thing I will add to your wonderful description there, because I think cross syndromes are so important to talk about when we're talking about glute med weakness,
Yes.
is I always think about the anatomy of the glute med, right? So we have
Mm-hmm.
anterior and posterior fibers, which means we basically, it wraps around the side of your hip,
Yes, it
right? So
does.
we have fibers that kind of help more with that external rotation, but we also have those anterior fibers that attach to your femur, right? That can kind of help with that internal and external rotation of that femur, right? So moving your knee in and out. And so sometimes it's like if you're in a position where your hip is forward, right? What's that going to do to those fibers? Well, those anterior fibers are going to be shortened, so they're going to like that position, right? They're
Yes.
going to be like, oh, this is great because I get to be short, I'm strong. But then all those posterior fibers are going, wait a minute, I'm super lengthened and stretched out. I can't fire the way I want to.
Mm-hmm.
I'm going to shut off. Right. So you might have part of your glute med that's working really, really hard, but the rest of it doesn't know how to follow.
Mm-hmm.
And so you have to be able to then look at those symptoms and say, okay, well, what other muscles are not working that we need to get to work? And what muscles can pull that hip back in a position that the glute med fires appropriately? So
Yeah.
that's always the thing that I always have to look at, right? When we're looking at the whole hip complex is like, okay, yeah, this isn't working, but if I don't get that hip in a position to fire it appropriately, it's not going to turn on no matter what I do.
Yeah.
So,
Yep.
so yeah, that goes kind of ties into an assessment thing too, right? Where we're trying to move into like, how do we look at this? How do we assess it, right?
Yeah. Jump right into your assessment then. That's
Yeah,
perfect.
yeah, absolutely. So when I do my assessments, right? I'm looking at their walking gait, which I think we talk about. I think every time I'm on this
You say that
on this episode.
100% of the time.
Yeah,
Do you think it's important?
maybe. Let's ask
Maybe.
the audience here.
Yeah, maybe a little bit.
But yeah, so I think looking at their walking gait is super important, right? If they have a super weak glute, you're going to see it right off the bat, right? I can stand here and if I'm walking and my glute med is weak, my hip's going to drop
Yes, it
every
does.
time.
Yep.
Right? We call that the Trendelenburg test. But
Yep.
if you don't have the stability to keep your hips even, that because of that glute med, your hip's going to drop every time. And over time, that can cause a lot of issues. So we're looking at their walking gait, how they're moving that way. B, just getting them on the table. I do a lot of range of motion. So just having them do active range of motion, right? Can you even get your leg, if we're in a sideline position, can you go up against gravity? In a sideline position and actually activate and abduct that leg, right? Bring it up off the table.
Yeah,
Or
right.
are you not able to do that, right? Could you do it in a standing position if you can't do it sideline, right? Like, so, can we get some of those other ranges of motions to kind of, can I passively abduct you and do you feel like you're cramping when I bring up there? Because a lot of times if you're cramping when I'm up here, it's probably because you're trying to overly use something else, right?
Mm-hmm. Yeah.
So I'm always looking at that stuff. And then also just looking at, like we talked about hip complex, what are the things are tight around there? What do I need to do? How are their hips positioned so that I can kind of adjust as I need to get it to actually activate and turn on when we do things?
Yeah, yeah. And I will say, going into kind of our assessments, the glute med isn't necessarily, I'm going to be honest, it's not usually the number one thing that I'm going to. As far as if there is a rehab process, and let's say, I'm going to say, because probably the most common that we're going to see that we're going to have a discussion about glute medius is going to be hip pain.
Mm-hmm.
Usually, what I'm starting with first is like that McKenzie assessment and starting with a directional preference type work. If we can classify the hip as a derangement, then great. Or even if it's like a dysfunction, contractile dysfunction, adaptively shortened muscular tissue somewhere, regardless, we're going to need some sort of repeated load or repeated load with weight.
Mm-hmm.
Then usually the glute medius is something that comes up a few weeks down the line, or like 4, 5, 6 appointments down the line, where it's like, okay, good, we've cleaned up a lot of the primary pain and the loss of function. However, I know if we don't bring glute med on board, we're always going to kind of fail to have that final stabilization part of things with it. And as part of my McKenzie assessment, if I suspect early on or later on that maybe glute med is not only just like the watching them walk, but we could do kind of like standing march in place where it's like bring your knee up 2 seconds, bring it down, bring your knee up 2 seconds, and do that like 3 to 5 times. And if that hip definitely just goes boop, boop every single time,
Mm-hmm.
then you know it's the leg that you're standing on is insufficient. That's why the pelvis drops down below Trendelenburg, or however we're supposed to say that sign, right?
Yep.
But I also like isolating it with functional muscle tests as well too. When a patient is laying on their back, so what we call supine, we can actually bring the leg abducted out to the side kind of by about 30 degrees And it's nice because then you could have the entire leg externally rotated and give them a really good 3 to 5 second blast of movement. And then when you go to turn the foot in and then do it, and usually the one where the foot is in, turned in, that's kind of elongated more of the glute medius. And then if that leg just melts down and I could push that person's leg right back to midline, even with them not loading with gravity, and I could still melt that, we got a real problem. And we're going to get
Mm-hmm.
going with exercises, which we'll put into the how we fix it section. So I don't want to get all of it included in here. But for the most part, that's kind of like where it's going to. I usually find it's not the number one thing that I'm jumping to right away, unless it's really stinking obvious. Like somebody walks in and that hip is just plopping, plopping, plopping. Then it's like, okay, we're going to get you some pain stabilizing stuff, but like maybe on visit 1 or 2, we got to get this glute medius going like ASAP.
Right.
Otherwise, we're going to stay stuck in the mud, right?
100%. And our bodies are so smart, right? So, like,
Mm-hmm.
we compensate so well. So, you and I do not see that patient that comes in with the hip dropping probably a ton of times, right? Like, maybe one in every 10 people, 12 people, 20 people that I see, like, well, I see like a significant hip drop where I'm like,
Yeah.
oh, okay, we need to fix that, right?
Yeah. I
Usually,
agree. It's not super common to get that. So
yeah,
thank you
yeah.
for corroborating.
Yeah, absolutely. Like, but so when we do see that, yeah, 100%, I'm like, okay, we definitely need to hit this. Otherwise, yeah, you're definitely like, okay, there's a lot that can go on here, and maybe some other things that we're compensating
Yeah.
we need to take care of first before we hit that glute med and reactivate. So yeah.
Perfect.
Um,
How about you talk about your solutions? Because we're beating around that bush a little bit, both you and I. So
yeah.
Let's just go right in for the kill on it. All right, take the floor first, please.
Yeah, absolutely. So my fix as an athletic trainer, massage therapy probably starts the same way, right? So after we do our assessment, I'm saying, okay, what muscles in the hip complex are overactive that I need to get calmed down? Because if you don't calm down anything overactive, it's going to try and immediately take over anything I try and do with a weak and inhibited muscle like the glute medius. So, if our hip flexors are tight, if, piriformis is tight, anything like glute max, all
Mm-hmm.
that stuff, I'm probably hitting that with like stripping it, doing any kind of trigger point work, anything like that, maybe having them foam roll, like doing some stretching
Yeah.
to get that calmed down.
Mm-hmm.
And then, maybe I kind of assess their hips and say, hey, your glute med seems lengthened. Can we activate your hamstrings to pull your hip back? And then we can get you into a position that your glute med can then be activated, right? But you want to make sure that, or I always want to make sure that the overactive muscles are calmed down, and B, we're getting that hip in an optimal position of that pelvis being neutral before we activate that glute med, because otherwise it won't turn on properly. And I'm
Mm-hmm.
just training it in a shortened or lengthened position based on where it is. And that's not going to help them, right? At the end of the day, their muscle is not going to fire and they're going to start compensating again. So that's kind of always my approach.
Mm-hmm.
From a more massage therapy thing, right? Again, we're kind of looking at like the whole hip complex. I might do abdominal work, I might do low back work, things like that to just get them in an optimal position. And then maybe we discuss some things that they can do on their own to kind of help activate and fire the way they need to.
Yeah. Yeah. I love that. A lot of that was really good. And what I'm going to say, they're going to echo. I think what we're kind of going to say is a lot of that stuff is going to be precisely overlap. It's just going to be a slightly different tool. But
Mm-hmm.
what's nice about like physical medicine is sometimes we obsess about like, we got to pick just the right technique. The reality is there's multiple ways to address that muscle tension that you're talking
Absolutely.
about. So like, I love that you said like the hip flexor will get tight and we need to work into it. You and I probably don't do the same types of trigger point work
Probably not.
and stretching, active release there, because with mine and my school of thought and discipline is I'm starting with our McKenzie method assessment. And usually my number one thinking on it is I'm trying to say, like I said, typically it's going to be like a lumbar or a hip. And it's seeing like if we can classify that as being a lumbar or a hip derangement, then we're starting with the repeated movement exercise. But here's the thing, the repeated movement exercise doesn't just exist in a vacuum. It's not just all about like cleaning up the derangement at the lumbar spine and moving the disc. It's not all about taking that hip that's not centrated just right and putting it back. Some of those things that you talked about, like, hey, glute med being weak and like maybe the middle and the inferior divisions of glute max being insufficient. Well, through reciprocal inhibition, if we're doing like a repetitive press up extension, or if we're doing repetitive hip extensions, well, we know that is also not just fixing the lumbar spine and the hip, but that's helping to shut down iliopsoas.
Mm-hmm.
That's helping to sort of melt a little bit of like the top fibers of the gluteus maximus. And because those fibers are going to be shutting down through that mechanical movement, you neurologically start to bring up glute medius. Now, that's not going to fix it all by itself, but
Right.
at least we're getting the ball in the right direction. That's then why we do some table therapies, like some trigger point pin and stretches. I really like, we were talking before the call, that I really like doing, because I know piriformis is usually a guy that's going to try to put on the cape and pick up the workload.
Mm-hmm.
So if we do stuff where we're like, taking that leg and pulling it out and doing like a thumb pin stretch and stripping out that piriformis to quiet it down so the glute med could finally get a chance to sort of like, oh, I got some breathing space in here and I could start to turn on a little bit. Those are all the things that we're going to want to get into. Depending on how insufficient of a glute medius that we're looking at, if it's pretty significant, then starting something unloaded with like clamshells is a good starting point. That's
Mm-hmm.
still a good exercise to give anyway, but I find like a lot of people have kind of already gotten onto that answer and have sort of integrated that as a home exercise. So I actually really like challenging people right into like, all right, let's get going with like one leg balance stability exercises, teach you how to actually tripod up on your foot, and then that way you could actually work on that, keeping your pelvis level while you're
Mm-hmm.
balancing on a foot. And then as that gets too easy, circles, then star patterns. You said like Y's and everything. I pretty much like also put a lot of that into our home treatment plan as well too, but very rehab driven on this. Anytime we're talking about a muscle that we're going to say, hey, strengthening, it's got to get back up in sufficiency. um, I wish I could tell you that there were adjustments and massage therapy techniques that are going to do that, not directly on the glute medius,
Mm-hmm.
but the other muscles, like you said so eloquently and perfectly, is you got to take those guarding patterns away so that way this guy can actually start to work the way he's supposed to.
100%. And
Yeah.
I love that you said standing, single
Mm.
leg balance, right? Because what position does that put our hip in? Well, if we're in
Yeah.
neutral, right,
Yep.
it keeps us in neutral, right?
It
Whereas
does.
clamshells, a lot of times people make the mistake of hiking their hip way up to do
Yes,
these
they
clamshells,
do.
and then they're doing clamshells with their hip flexor instead of their actual
Yeah,
glute med, right? So
that's true.
that I think a lot of times when people try and self-correct on the internet based on like I'm
Yeah.
gonna WebMD it and I'm gonna see like what
Yeah.
what's going on, they don't nuance or tease out maybe like the things that we're looking at as clinicians and
Yeah.
saying, oh, you know what, your hip flexor is already overactive. We don't need to do this exercise because you're
Mm-hmm.
gonna just cheat with it,
Yeah.
and I don't need you to do that.
And then how about this, just to add a little bbit more to that, the way that I get around this precise problem that you said. So I'm going to throw in a little bit of a free clinical nugget for everybody. But if you are doing clamshells and you're like, oh, am I utilizing my hip flexor? The best way to make sure you don't is on your position before you start doing your set of 5, 10, 15, is you reset the position of your pelvis and spine. So you hyper arch, you hyper bend, you do that like 2 times, and then you find the middle. Then you've at least taken a lot more of the hip flexor out of it. And now you're probably getting a little bit more of a true glute med. Anytime I give the clamshells, that's how I'm teaching people, because like they need to find neutral. If they
Mm-hmm.
can't find neutral, then they're not going to use the muscles correctly.
Correct.
And again, getting a little ahead because this can be a future podcast, but that's the exact same strategy I do with glute bridges as well too. Because it's like if you don't put that pelvis in that spine and glute bridge, forget everything else you're doing. You're not going to be recruiting the muscle patterns the way that you need to. You got to stabilize neutral first, then get the leg positions right, and then if and only when you've done those two things will your exercise actually work maximally for you.
Absolutely.
Yeah, that was a little bit of a sidebar, but I still think incredibly valuable information. So thank you for steering it that way.
Yeah,
So
absolutely. Well, thank you because I think this has been phenomenal. But
I hope so.
yeah, I
Yeah,
think it has been. It's been phenomenal for me. I've learned something, if nothing else.
I
So.
learned something too. And I think that's part of the reason why we like to continue to do this. One, it's just, I think both Rebecca and I really do genuinely like patient education.
Love it.
It's one of our favorite parts of our job. And
Mm-hmm.
quite frankly, it probably is the most important part of our job, is for people to actually understand how their body works and how the things we're going to do are going to work in here. Like, people care about like what we're going to do. They're going to care about how the process looks, but what they really care about more than anything else is the why behind it.
Mm-hmm.
If we sell the why of like why this is going to work and why it's going to help, then you're going to have the outcomes that you need to have at home. Right.
Definitely. Absolutely.
All right, awesome. So on that note, we're going to wrap up our 10th episode of the Be School, Be Better, Be Empowered. Nice little tidy bow on our glute medius discussion. And the
Mm-hmm.
reason why we didn't just pick the whole glute, in case somebody is curious and wondering, is we felt that there were like multiple other muscles in there, like the piriformis and the gluteus maximus, that are also just comprehensive enough that they deserve their own discussion. So, stay tuned for months to come. Those will eventually
Absolutely.
be topics, all right?
Yeah, definitely.
But I am Dr. Emery Pitcel, chiropractor here in State College,
And I'm Rebecca Hall. I'm a massage therapist and an athletic trainer.
also in State College.
Also in State College,
State College,
correct.
Pennsylvania, right?
Yep.
Well, we want to thank you all for joining us in June. If you made it all the way through the podcast and you found this information awesome and helpful, please make sure you share it with others. Give us a like, leave us a comment about what you liked, what you didn't like. Less of the what you didn't like, though, please.
Or what you want to know.
Or even topics of things that you want to know, because like we do actually take what people kind of say on there, and we do sort of say like, yeah, that would be a good topic to talk about next. So like if you have something you really want to learn about, like let us know. We'd be happy to consider putting it onto the docket of things to talk about next. Right?
Absolutely.
All right. But otherwise, thank you so much for joining us. If you watch this whole thing and you're inside, go outside and get yourself some vitamin D, right?
Absolutely. Enjoy the summer while it's here.
Absolutely. Well, once again, I'm Dr. Emery.
And I'm Rebecca.
Thanks, everybody, and have a good one.